Dr. Rajesh Sinha, we would like to be excused for jumping the queue as Dr. Rajesh has to go to another hall. He will be speaking on iris and pupil reconstruction with cataract surgery, different strokes. Dr. Rajesh Sinha. He's a
Thank you.
professor at AIMS and he was our earlier treasurer at AIOS.
Thank you, Dr. Satyajit. I'll be showing you a few scenarios. You all must have, encountered situations wherein there's a cataract and you require some pupilloplasty or you require some iris repair. So there can be various scenarios, and it will take a lot of time. So I'll just show a few scenarios with some logic why it was done like that. So it's a case of a partially absorbed cataract. You can see here it's a membranous cataract with an iridodialysis here, and the iris synechiae and everything. So what are the issues? One is that whether we should repair the iridodialysis first, or we should put an IOL, multi-piece IOL in the sulcus. So I feel we should repair the iris first, because if we make a membrane opening in the membrane and then do iris repair, then in that case there can be pigment release, we can go into the posterior segment, there can be inflammatory mediators release which can go into posterior segment, and that can cause CME. So that was one. The second issue was that when you release the synechiae from here, I'll just move a little fast. When you release the synechiae from here, what happens that the iris tissue is all, they are crumpled a bit. So in such case, when you pass the needle from the tip of the iris here, you will see that the whole of iris is pulled onto one side, and it causes some degree of notching. It has not caused in this bite, but in the other bite it will cause that you can see here that the whole thing is going away, and it is from the tip only. So what you need to do is that once you pass the needle, you have to stretch the iris. The folds that are created, that folds have to be opened up. That is important, and that is what is the thing. The basic idea is that you should just oppose the edge of the iris tissue at the root of iris and not tighten it very tight, otherwise it will cause notching of pupil and you will not have a pupil which is circular. Here I am trying to stretch it, so, and very gently, so that as you can see here, the marks that you can see, these are all opened up folds, because that is why it is looking like white, depigmented kind of. And then you put more sutures, you have to put multiple sutures, and then once you have done with it, then you do a membranectomy and put an IOL in the sulcus, a multi-piece IOL in the sulcus. And the basic idea is that the edge of the IOL should not be in the pupil at all, even if you have the little bit of notching, although you should aim for no notching at all. This is the end of the procedure, and this is how it looked like. There was no notching, but because of the atrophy of the iris and because the folds were opened up, but still there was atrophy, so there was a little bit of pulling here. The ideal one would be like this, but because of the atrophy of iris, it was slightly pulled, but still the edge of the IOL is behind the iris. That is what one should aim for. If you have a traumatic cataract with iridodialysis with a swollen lens, in such a case you need to create a space. Now if you want to create a space, you have to do a cataract surgery first. So release the synechiae here and then put iris hooks. You can put iris hooks here because the iris is not fluttering. I have not put the iris hooks, but in a large majority you may have to put the iris hooks here, because sometimes the iris will flutter, and then it will come into your probe, and then it will cause damage. Now if you have an iridodialysis like this and you have done a nice phacoemulsification, you can expect some amount of zonular dialysis also in this region. So endocapsular ring should be put in all these cases in the bag, and then you put the IOL in the bag, and after that you do the repair, because now you have created a nice space. And then even if there's a pigment release, it will remain in the anterior chamber only. You can, while removing the viscoelastic, you can remove it because there's no opening in the posterior capsule. And this is what you should aim for, a circular pupil at the end of the procedure. Another scenario, or the last scenario actually, iris coloboma with cataract. Now, in such a case, if you do a cataract surgery, put an IOL, what will happen that this part will remain aphakic and this will be pseudophakic. So your idea is to do the cataract surgery first and then repair the iris in such a way so that you can get a nice circular pupil. So the cataract surgery is done the same way as in anyone. Sometimes you get a very calcific cataract in these colobomas. These are hard and calcific cataracts. But this was relatively easier one. And then in all these colobomas, you have a tendency because of the loss, there can be some loss of zonules also. So in all these cases, we should put an endocapsular ring, inject viscoelastic in the bag, put an endocapsular ring, and once the ring is there, now you have to do the repair. Now when you are doing the repair, after putting the IOL, you should remove the viscoelastic from the front and from the behind the IOL, because once you have done the repair, you will not go behind the IOL. And then after that, you inject high viscosity viscoelastic, and then the first suture should pass through the intended edge of the pupil. That is important. So this is the first suture. What I want is that the edge of the pupil should be like this. So this is the first knot that I'll tie, and once you have done that, then you can go ahead and pass 2 more knots will be required in such cases. So 3 such knots, single pass for pupilloplasty, and then once you are done with it, then you can remove the viscoelastic, and you will have a reasonably circular pupil, and the pupil which is an adequate size also, so that you can view the posterior segment as well. So thank you very much for your patient listening.
Meticulous surgery, sir. I could see that 10 more people, I think at least 10 more people joined in the hall when your videos were playing. Questions, if any, Satyajit sir has.
Amazing, amazing video. Very good.
Thank you.
Thank you very much.
Thank you. Yeah. Yeah, yeah. Yeah. Yes, we can. Only problem is this, that in a circular pupil, because it was still margin was circular, but because of the atrophy, it was pulling the iris tissue, but it was still, the IOL edge was inside. So the center of the IOL was behind and along the visual axis. So that was serving the purpose. Now, if you pass a knot like this, then you will create a fold in the iris tissue. That is one issue. That is one problem. So I didn't want to create a fold, because that fold, either it will go behind or it will come up. Other way of doing it is that you can just cut it, just put a nick and then put a suture. That can be done, but then when you have such a large dialysis with an iris atrophy and you see that your lens is well behind and the edge is not coming, it's better to, be less manipulative and do less manipulation in such cases.
So I just want to understand one thing.
Yeah.
You said that we should be doing in cases the iodelic repair first. But what I mostly prefer and doing, because of the inadvertently hitting the anterior capsule while doing the repair.
No. The
The
iris repair is not done. In the second case, I did the cataract first.
Yeah, I saw that.
And
In the
then
first
did the iris repair. In the first case, I did the iris repair first, because there was a membrane only.
membranous lens
So
was
if you cut the membrane and put the IOL and then do iris repair, then pigment release and inflammatory mediator release will be there, and that will go into the posterior segment, and that can cause high chance of CME.
As a beginner, I initially started doing the iris repair, iodelic repair first, so that I do not puncture the anterior capsule while the repair. Secondly, the one more point, that before doing the pupilloplasty, what I prefer is putting some pilocarpine, so that we know that how much of the rest of the pupil is there.
I agree. That I completely
Pilocarpine
agree.
has
I
to
mean,
be put
obviously,
first.
all these things you edit and then show. Obviously, you would not like to have a very dilated pupil and then do pupilloplasty. You would like to put the pilocarpine and then see what is the shape, and then you will put this.
Especially in the coloboma cases.
Yeah, especially in the coloboma one.
Thank you, sir.
Yeah. You could see when I started doing the repair, then the pupil, which was, large, it had come down to a little smaller one. It was not that big.